Welcome. On behalf of the Patient Safety Authority, I would like to welcome you to this webinar entitled Artificial Intelligence in Medicine, Risk Management, and Litigation. My name is Michelle, and I will be your moderator for this program. A copy of today's slides are available using the link provided in the chat box. The chat box can be found by clicking on the chat button in the lower right-hand corner of your screen, and then you'll see the chat bubble. You can also find the Q&A box in the same location if it's not on the right side of your screen already. This webinar will be available in a few weeks on the Patient Safety Authority's YouTube channel, and we welcome your comments or questions. You can enter those into either the chat directed to all panelists or the Q&A box as you think of them. All materials are provided for your educational use. Now I'd like to introduce our speaker for today's webinar. Matt Keris is an attorney at Marshall, Dennehy, Warner, Coleman & Goggins, PC. He has defended doctors, health systems, long-term care providers, and medical device manufacturers for more than 2 decades. He's a shareholder in the firm's healthcare department and chair of the Electronic Medical Record and Audit Trail Practice Group. Matt has developed substantial experience in electronic medical record preservation, production, and discovery matters, having authored a book on the subject, Electronic Medical Records and Litigation, for Thomson Reuters. With a primary focus on assisting clients with legal matters related to EMR issues, Matt also provides consulting services on a national basis to attorneys grappling with EMR and audit trail discovery issues. In this capacity, he's brought in as a legal consultant to provide guidance on managing this unique aspect of litigation. Matt serves as a resource for clients and the legal community on issues pertaining to EMR, and his commentary is routinely sought by legal publications, including the Legal Intelligencer, Law 360, ED Legal Letter, Risk Review, Litigation Management, Counterpoint, and Becker's Hospital Review. Matt also serves as an editor of the Patient Safety, a journal published by the Patient Safety Authority. Matt, I now turn the program over to you.
Thank you, and thank you all for participating today on this topic that's cutting edge, and I simply want to ask all of those of you that are on the phone here today, are you ready? Because I believe where we are now is we're on yet another precipice, if you will, in the revolution of healthcare technology, with the anticipated increased use of artificial intelligence and medical decision-making in the next couple of years. Today's program is going to be an overview of some of the issues, or where we are with AI in healthcare, where AI is currently being used in healthcare, where it is going to go very shortly, and some of the health risk management issues that you need to start thinking about now moving forward, some practical questions and thoughts, and some bigger picture things that we need to start thinking about moving forward, because it is going to be a significant part of healthcare very soon. And I think, as some of you who are on the phone here know me, and as the introduction outlined, I've spent many years now talking about the electronic medical record and just how the electronic medical record has changed medicine as a tool for recording patient information and how it's used. But where we're going now is an even greater reliance on the electronic medical record, because as opposed to what it's been used for the most part right now is to document healthcare, now you're going to have an interaction with this electronic medical record, where the electronic medical record is, if for a lack of a better explanation, is going to speak to the healthcare provider and say, basically, and this is where it's going, it's not quite there yet, in some ways it is there, it's going to say, hey, considering everything that you see with this current patient, based on what we've seen in the past, maybe you want to consider this or consider this treatment option. So it is going to be quite the change, and it's coming very soon. So with that said, I'm going to advance the slide here for a minute. There we go. I'm paging through to the first slide, which is page 4 for your information. And as I alluded to, in my humble opinion, this is the next step in the EMR evolution. We are going to see artificial intelligence used similar to what we are very accustomed to as consumers in this world and it's particularly in this COVID era, of Netflix and Amazon, where these platforms recommend movies or music or track what you watch at certain times and what your interests are and make recommendations. Or if you're shopping, we all know on Amazon that if you purchase something, you will also get those reminders or suggestions. With people who buy this, they usually buy these other products. Or with our various social media platforms, whether it be Twitter or LinkedIn or Facebook, that when you start looking at certain web pages or certain things that are found on the social media, you might start seeing advertisements come up or suggestions for people you might know based on a whole number of things and based on the time of your posts. You're going to essentially see that technology or that computerized thought process and have it applied to medicine and treatment options and other types of things moving forward. So the goal is to have AI. Basically what AI is basically the attempt ultimately to have the electronic medical record system or healthcare EHR system achieve human-level decision-making through a combination of the data in the EMR system and then having mathematical algorithms applied to that data that's been captured over the last 15 years or so by health systems with their electronic medical record system to give treatment options or suggestions for different things. Essentially, we've had electronic medical records now for greater than 15 years, depending on where you are with the integration, and it's almost everybody has electronic medical records now, and it's taken till now, or in the last probably until about 6 or 7 years ago, people were progressing that way, and there's still some components of the paper record, but it has 15 years of patient data roughly for these algorithms to be applied to, just like your Netflix has maybe 15 hours a week, whatever you're watching on there, to process and then give you recommendations for what you should watch, or Netflix. And importantly, the last bullet point on this slide here is look at the money that's being ready to be spent on this aspect of healthcare. $2 billion as of last year spent on AI-related activities, and it's not just all treatment recommendations. We'll go into some of the other areas where AI is being used right now. But $2.1 billion last year, and that spending is going to increase almost 20 times that within 5 years. Just think of that money. Think of that's a lot of money, and it's going to, again, increase 20-fold. So it's coming, and that's why I say, are you ready? Because this is really going to get interesting very quickly, and we need to get our arms around this and think through where our potential pitfalls are and where the errors are, and how this information is going to be used by our clinicians, and how it's going to be shared with our patients. Moving on to the next slide, I want to talk a little bit about where we are right now with AI in healthcare. Like I said, we're not completely at a point where we're having this Netflix or Amazon experience with the EMR making recommendations, but you see it in a lot out there that's already, whether you know it or not, AI is involved. The patient monitoring with the smart devices, the watches and the home assistants, that's considered AI in healthcare. You have AI being used with administrative functions such as voice recognition technology for dictation, kind of like your Siri or your Alexa. That's considered AI. And with automated care schedules or appointment reminders, that's artificial intelligence. And the first big area clinically that we're seeing where AI is being used is primarily in interpreting imaging studies and pathology specimens. And we'll get into a little bit more detail on these issues in a few moments. And again, the next big step is the computerized treatment recommendations, the algorithms applied to the electronic healthcare record for treatment options. That's where the big step, the big jump is going to be made within the next 5 years. So let's talk a little bit about right now the AI that's being used, and we see it already with some of these mobile devices, and that they're assisting with remote monitoring. It's the Google Home or the Nest, those types of things, where people, particularly we're seeing with some elderly people, where maybe they're living alone or by themselves, where these systems are listening in and listening for various cues. Some people are using it to see if there's perhaps a spell where they're confused or they're not talking right, where these devices are being used to predict if there's an upcoming neurological issue, as well as you see it with the eye watches, and how we know that they're being used for tracking, cardiac symptoms. We know that they can and they have predicted arrhythmias, and people's lives have been spared because of these devices. And interestingly, over the last several weeks, and I've been listening to and following the way some of these the smartphones have been used with respect to COVID-19. Fortunately, I have not had it. I feel increasingly like I'm one of the few that has not been infected by COVID-19, and I'm sure most of you can attest that for those who are here from hospitals is that they're recommending for some patients, because of the overwhelming census at hospitals for various reasons and COVID, that they're recommending patients to get pulse oximeters that you plug into your phone so that they can remotely monitor ill patients. I have a client who's a healthcare provider who that exactly happened to, and they're following his pulse oximetry remotely. I've also read that, I think this was in Europe, that by the use of a smartwatch, retrospectively, it was shown that the smartwatches pretty accurately were predicting a COVID infection based on the patient's vital signs, their personal activity, what was going on if they were moving around a lot. And because these smartphones and smartwatches are basically giant GPSs, they're predicting if a person will have COVID or not. That's amazing. And I think with the smartphones, it was not by design, but it has become the reality. So these are good things to allow remote monitoring of patients through these devices. These are wonderful things and are a benefit to medicine. However, let's think of some of the downsides of the remote monitoring as well. And the biggest thing in my mind, deals with calibration and programming. And if these devices if there's pulse oximetry or some type of cardiac monitoring where the device is not calibrated correctly or it's programmed incorrectly, there could be no benefit of the device because it's giving bad information or perhaps no information at all. Or perhaps there's a reliance that the devices are giving relevant information when in fact they're not, and someone relies on these devices to their detriment. So that's one big concern I can see as a defense lawyer in where these cases may come up, is that if there's a reliance on these devices for the rendering of medical care, what efforts are being made to make sure that these devices are being programmed correctly, calibrated correctly, and if the patient knows how to use them correctly? And one could argue, because you can raise any type of theory of liability or make any type of criticism, that if the healthcare provider is going to increasingly rely on these types of devices and use them, that the need to make sure that the information coming from these remote devices are correct. It's basically, with these devices, it's very similar to some of the medical device litigation I can see. And you could see perhaps, if a certain type of device or remote monitoring thing is being used and recommended, and if there's an error or a problem with that device that comes out later, there could be like a products liability component to these cases as well, which is quite interesting. But ultimately, if it's a physician or a health system that's pushing or advancing the use of these remote devices, there could be a medical malpractice component to that. And perhaps, again, if it's a case where the medical device is malfunctioned or was designed incorrectly, where there could be a products liability component to the case as well, which is quite interesting because we don't see much of that in our cases. You're seeing more and more of it, but that's where there could be an issue. And a question can become too, if who's going to be reliable or who's going to be responsible for the calibration? Is it the manufacturer? Is it the healthcare provider? Is it a combination of both? So these are things obviously we don't have the answers to. These questions have not been necessarily raised. We can see maybe they've been raised in cases where there's like a pacemaker being used or some other type of remote device. You can see similar arguments applied here, but that's things we need to be consider at this point. Additionally, with an increased use of these devices, you're creating an avenue for nefarious behavior as well. I think I anticipate most of us who are on the phone here, we're all involved in some way and keep up to date in health risk management. You hear about hackers and how they're taking over health systems and holding the information ransom for Bitcoin and other things, but there's also the distinct possibility that if a hacker wants to get involved with a pacemaker or some type of cardiac device, that they could potentially play with the device settings and cause death if there's someone who is dastardly enough to want to go in and play with some of these pacemakers and medical devices as such. The more we use these things, the increased targets our health systems become, even more bigger targets our health systems become, because they're already, I've been told by people who know the black market, the black market considers hospital EMR systems to be banks because there's so much information. You have Social Security numbers, you have Medicare numbers, you have dates of birth, you have height and weight, you have eye color, hair color, all those types of things. With the increased use of these devices, you're just perhaps making yourself a bigger, easier, and more susceptible target for those types of computer crime and fraud, and that can ultimately come into and affect the hospital in some way. So these are some of the other things you need to consider in addition to the good parts of remote monitoring. Moving on to the next slide, slide 7, is another example, and we talked about it a few moments ago, where AI is being used, and that is with dictation. You essentially, I use the terms, the current use where you use Siri or Alexa. It's not that, but it's essentially the same. You use that same type of technology, the voice recognition technology, for dictation, which we all know Siri and Alexa are pretty darn good and getting better, but they're not 100% perfect. But they'll use that type of technology for physicians to use in the electronic medical record, and then after the physician utilizes the computer-assisted program, others will listen in or check the dictation and make sure that it's medically accurate. This is one way where dictation is being impacted by AI. I have also, it's not directly AI related, but my understanding is there's another type of platform for medical dictation that's that doesn't use AI. It deals with physicians dictating, and their dictation goes into a digital recording, which is then sent to a medically trained person, sometimes medical students, to listen in, interpret the audio, and then produce what the record says. So that is not necessarily an AI way of dictation, form of dictation, but it is another form of automated dictation that's being used out there right now. Obviously, AI and dictation is being pushed because of the immense dissatisfaction by physicians towards the use of the electronic medical record. It's cumbersome, it's confusing, it takes away valuable time they have to meet with the patient because they feel burdened by it because it's cumbersome, and there's a lot of dissatisfaction and burnout, and there's a big push for this to help with those types of things, which is great, and we want more time between the physician and the patient. But the cons that I see with respect to this new form of dictation is that even though Alexa and Siri is great, their accuracy is in the range of 95%, which is still great, but in the business that physicians do, it's still not good enough. And unfortunately, it's my understanding that the technology, although it's very good, is still dependent on fairly pristine conditions in order to get as close to 100% accuracy as possible. Factors include background noises, microphone use, interpretation can be impacted by accents that people have, and their use of medical and text abbreviations in their dictation. And those have always been issues. They will always remain issues. A busy emergency room is not a great location because of background noise for this type of dictation, and the computer or others may not hear words or may hear things that are different. So although this is wonderful, and I hope that there is a near 100% accuracy rate or with this dictation in the near future, I'm not holding my breath, because again, the healthcare environment is not great for recording. And a concern that I have also, or there's two things that I have, is, well, the main one is if our physicians are familiar with how their dictation is being done, whether it be the Siri, Alexa, AI component versus people listening in, are they going to be diligent in reviewing their proofreading their entries? If they know others are doing it, if they know they put it in, if they know there's an audio recording of it perhaps, are they going to be as vigilant in looking at their dictation and their entries as they would if they had typed them in? They may consider these devices to make it less important to proofread, but when we know that it should be remain just as important. So we just need to watch that, in my opinion, is to make sure that even though these are great things, they theoretically free time up for our physicians to use them, we need to remain just as diligent now as we have 20, 25, 30 years ago in making sure that they're proofing their records. Just the other issue I mentioned, there's two issues. One of the if people are using the dictation service where there is an actual digital recording of the dictation, a question may come up in cases where there's a request for that audio. And if the audio is if it's being preserved, there's a good chance that it will be requested in litigation. If audio is immediately deleted or erased after it's used, it should be made. There should be a policy that sets that forth, so there's no allegations later on that there's type of spoliation or something, funny going on if it's been erased. You want to have that policy in place to explain why the audio has been erased or recorded over, whatever term you may see it. Moving on to the next slide. Again, this is under the where AI is currently being used in the administrative side of things is dealing where I see it with calendaring or scheduling if it's automated. You see some issues coming up on this. I actually had a couple of weeks ago had a national reporter contact me from the defense perspective as to a case he was aware of in an area, not in Pennsylvania, about a record alteration issue. And I think it all stemmed from this type of automated calendaring or automated results function that you may get with some testing, and it resulted in a big lawsuit and some confusion that unfortunately the patient was injured and it was a real issue in the case, and they wanted the defense perspective as to what occurred. But where we're seeing some use of AI right now is dealing with scheduling, just the automated scheduling, where you come in, there's a recommendation for follow-up, whether it be, if for example, if there's a cardiac patient who has a chronic but stable condition, that automated visits come up, there can be either an email or a letter saying, hey, your next visit's coming up, you should be there. And that's great. It eliminates a function of the office staff. If it's automated, there's going to be less likely to miss routine visits, etc. It's a nice function. It reduces no-shows. It can ensure continuity in care. But there are examples of ways that these types of automated scheduling or automated results, how they're given out, can result in problems. For example, the biggest thing I see is if using my chronic stable cardiac patient as an example, let's just say he's got a condition, it's stable, he has his a quarterly visit, let's just say. And so he gets these letters, he anticipates these notices, and once he gets them, to remind him to come in, he'll go in, have his standard checkup. That's great. But what would occur if, let's just say, this otherwise stable cardiac patient has an acute event and he goes to an emergency room between normal visits? And he already received notice that his next checkup is 3 months from now. And he'll go into the ER. Unfortunately, they're discharges. There's no real issues. And is that acute event in the emergency room being reported to the cardiologist who's treating them? And automatically, if it's from the same health system, I'm sure it's easier to get that information to them. But the more we use these automated calendaring, automated reminders, patients are going to be reliant on them and assume that the physicians are aware of these acute events. And if for some reason the acute event is not being reported to the cardiologist, using my example, they may think that the next follow-up visit in 3 months is appropriate, where in fact the cardiologist may want to see the patient immediately or on a much nearer time than what was scheduled ahead of time. So the question becomes, if this acute information is going to be sensitive to the cardiologist, will they alter the routine standard reminder? And if not, a patient may be given the false sense of security that they don't need to come in right away. So the more patients are reliant on these things, the less likely they will anticipate that the doctors, kind of knows all this stuff's going on, and if they're not getting communications to come in, they may think that the later visit's appropriate. Another issue that may come out is if there's contradictory results for like a lab test, like the lab results go out, and this was the basis why the reporter called me, is that this patient got mixed results. The information, the testing date was correct, but it just got mixed results. One test result said things were fine. The other one says you may want to schedule an appointment. Patient wanted to hear that they were fine, didn't call back. That was the information they knew. For whatever reason, they didn't want to call back. didn't call back, should have called back, and as a result had a negative consequence. So these automated letters, automated countering, automated test results need to be watched. They should not replace a good patient-physician relationship when it comes to further follow-up. So now let's get into what we're talking about, where we're going on, the next big step, where AI supports treatment and diagnostic recommendations. This is both where the doctor or the electronic medical record system is going to give a suggestion and how it's used right now with pathology and imaging studies. Basically, when it comes to this, whether they're giving treatment or diagnostic or recommendations, and I talked to this at the outset, there's basically two components. There's the data, the EMR that's being utilized. Again, we have our health systems now have accumulated nearly 15 years or so of patient demographics, disease process information, treatment results, care results, treatment provided, and now they're applying these sophisticated algorithms to the data to give treatment options or suggestions or thoughts about what to do. What are the best ways to get, what are the best treatment options? What's the diagnosis, et cetera? It's kind of like with Amazon seeing your shopping history and making suggestions to what you do. Instead of the shopping history and shopping data being utilized, it's all the data under similar circumstances that these hospitals have accumulated, and it's basically the application of the algorithm is spitting out potential treatment options or diagnoses. It's essential. Think of right now, we've all heard of TikTok. And why are we hearing about TikTok? But it's my understanding that TikTok is probably one of the best social media algorithms out there. It's a Chinese-based company, but it's really good at looking at your viewing history and making recommendations of videos or things that you want to based on your history. It's really good. It's got a good rate, and it not only tracks what you're looking, it also tracks what you're declining, and it's making pretty good recommendations for you to look at, for these next videos, and it becomes addicting. And it's that TikTok is popular because of that algorithm, which is very secret and is used by them, by their company, and that's why there's concern about, some people have concern about it being associated with a Chinese company using, Western data or American data to make these recommendations. It's the powerful algorithm that they've used, which has made it so popular over the course. I mean, none of us heard of TikTok a year ago, just like none of us knew about Zoom a year ago, let's face it. But that algorithm is powerful, and that's where you're going to see the money that's going to be spent on AI in healthcare to make these differences in healthcare. So the result is going to be, in medicine, for clinicians, is that Netflix, Amazon, Facebook, TikTok experience. That's where it's important. So the implications of this is pretty positive. I mean, you're getting a computerized second opinion, which can't hurt, and it can theoretically reduce errors. And if you reduce errors, you're getting better care, shorter hospitalizations, and less claims. So there's really, from a clinical perspective, theoretically, AI's use is a benefit, and it will, and you'll see some benefits. But just like anything, there's going to be some downsides, and there's going to be some downsides that I'm predicting now that could be there. But there's also going to be downsides that we're not really quite sure about yet, and we won't know until we get into the nitty-gritty with this and to actually use these things where you can see where there's some problems. The biggest thing, and we'll get into this specifically in a moment, is AI, in my opinion, where it comes to treatment recommendations, should never replace a physician's decision-making. It should be used to augment it. And And there's no downside to that as long as it's going to be used as a tool to assist the healthcare providers make their medical decisions. But like anything in life, and we'll get into this in a moment, people may become overly reliant on the healthcare and perhaps get lazy or sloppy on it and not want to second guess it. And where AI will become more important than the healthcare provider's decisions. And we have to keep that in mind and constantly remind our people that it should not be what is recommended in terms of a treatment option or a diagnosis is not what we should be completely relying on. It's helpful, but the more physicians and more people just focus in on that computerized decision making, the more problems you can have. Additionally, because we've already, some of us have heard about fatigue associated in the dissatisfaction with the electronic medical record, how we have a lot of these warning pop-ups and people are just going right through them because it's overly cumbersome. We in healthcare risk management think these pop-ups are going to be beneficial because we're going to try to compute or to try to remind people enough so that there's no errors, but in reality, what we're seeing is that people are just blowing through these pop-ups because they're being used too much, and they're over-reminding, and they're just bogging things down, and people aren't spending time with the patient as much. So let's use the lessons learned, the workarounds that we're seeing because the electronic medical record right now, the documentation piece, is bogging down. We can't lose sight that, if we overuse or have too many second opinions or too many recommendations when a physician is interacting with the electronic medical record, you may bog down care, and there could be some repercussions for that. So we should use it, in my opinion, we should use it judiciously and not overly rely on artificial intelligence to make treatment options or suggestions every step of the way, because it'll become entirely overly cumbersome for our people, and then because if it becomes overly cumbersome, they may not even use it, and they're not even going to be using a tool that could be helpful. So, moving on to the next slide, let's talk about. We were talking before about AI. Right now, it's being used with pathology and imaging, and it's doing a good job. And what the computers are essentially doing is that it's learning. I can't explain how it's doing exactly, but they're looking at healthy tissue, they're looking at good images, and then they're learning where there's suspicious findings through pictures. And it's being used to assist already. And in some instances, the AI is better or has a better accuracy rate than humans. And it's actually, there's one app, and I don't recommend doing this, where people are taking pictures of skin issues and sending it to this app, and they're telling them whether or not they need to go to a doctor or not. So you're seeing that at all. So, it's improved accuracy. It could reduce human workload in terms of the pros. But the cons deal with what I see in our malpractice cases dealing with bias. If before an image is viewed by a human, if a computer has interacted with the image and made a recommendation, how that can impact the human reviewer. If a reviewer is made aware of a AI predicted or a CAD initial positive, the American College of Radiology talks about it all the time. It creates a bias that the human mind will want to think that there's something there. So if the human reviewer is aware that the computer has found something that's suspicious, the human reviewer will probably find it. And that's a good thing, I guess, but it also could increase the risk for false positives. Conversely, if a human reviewer is made aware of a negative finding before reviewing the film, ultimately, it could provide a false assurance that the study is normal. The computer doesn't see anything. I probably won't see anything. So you may have situations where to eliminate bias, where you may, have the computer review it and then the human review it, or you may need a final blind review in order to break the tie or to make sure that it's accurate. So how and when the information that's being used by clinicians, if they're made aware of findings or they review it, then they're made aware that let's just say, for example, a reviewer doesn't see anything, then the computer goes and does its own check and says there may be something suspicious here. You may be creating the bias where the reviewer then looks again and says, yeah, there might be something there. So you have to be careful about the bias associated with the use of computer-aided diagnosis. And I've also been made aware that, if our younger clinicians are using the AI with diagnosis, whether they be an imaging specialist or a pathologist, are they going to be training? Are they going to have as keen an eye as some of their older, more sophisticated people who train without the use of it? Are they going to have that eye to detail? So we need to be aware of that in terms of our training moving forward. We still want, it still has to come down to a human eye, but we need to really be careful in training our students in these subspecialties to make sure that they rely on their eyes and not necessarily become over-reliant on the AI. So as you've seen from my other slides, AI will improve care, but let's talk about some of the other things that may come up that we're not anticipating right now where you may see some issues. First, is there going to be with if a computer, in the example of where a computer is giving treatment recommendations or a second opinion, will clinicians become more defensive in their practice? If they don't think a patient warrants further checkup or further care or further testing, and the computer recommends it, are they going to be inclined to say, no, I'm not going to do what the computer suggests? You may have some clinicians who are going to be fine with their decision making and stand by and say, no, they don't need that other test. I don't think it's necessary. But you're going to have some people who are going to be over-reliant on the AI and just say, well, the computer's recommending it. It can't hurt, I guess. But we have to be careful of that because you may be creating more anxiety in a patient or making them go through unnecessary tests, which obviously creates the anxiety. So one of the potential pitfalls is defensive medicine and the problems that come with clinicians who may practice more defensively and maybe, again, overworking up a patient on certain things when perhaps they don't need to or wouldn't if there was not AI involved. And along those lines, and again, you can see as medical billing is scrutinized by third parties, you may see if a practice becomes overly defensive in its care, is there going to be a scrutiny on the breadth of treatment in the medical billing? Can there be a true, if there can be scrutiny into the algorithm that's recommending a whole host of tests if the doctors go through that, if that's necessary. So not only is there liability from perhaps a medical professional liability perspective associated with the practice of defensive medicine, but there may be a criminal or a medical billing element as well, and that's something we need to be aware of with these AI recommendations. You still, like I said a few moments ago, these AI recommendations should be used to augment, not replace, sound medical decisions. But it's human nature, and you're going to see some clinicians who are going to overly rely on the AI recommendations, something to be aware of. And what steps can we take? What steps, and we have to start thinking of this now, what steps do we need to make sure these clinicians don't fall into that trap? Another question is, what are the implications if a healthcare provider disagrees with the recommendations? What if, a computer spits out a diagnosis says it, let's keep it simple, that it's cancerous and the doctor says it's not. And in retrospect, the specimen was cancerous. That can create a real issue. And you may want to, if there is a conflict, something to consider. Again, I'm saying this from the defense lawyer side of things and maybe the health risk manager side of things, that perspective. If there is a non-alignment on a major medical decision, it's always nice for us, as defense lawyers to say, put everything in the record, document. This may be a new area of documentation where a physician may have to explain briefly why they disagree with the AI. It creates another layer, which I guess would be good in defending the case, but then if it also creates another layer, it also creates this burdensome system. Where we land with this, I don't know, but it's something we need to start thinking about right now, is that if there is a disagreement between the treatment recommendation by the AI and the physician, that if there's a subsequent review, which there will be, how will that be explained? We always say, put corrections in the record. If there's an amendment to the record, put it in. You document it correctly. In these situations, when you have this basically a second opinion and it's not being taken upon, perhaps it's better to have that physician spell out the reasons why they disagree at the time, and that'd be helpful in the malpractice case later on. I talked about, here's another issue, is will these recommendations be disregarded as a workaround? We have to be careful that AI is used the correct way and not involved too often in the interaction with physicians in the electronic medical record. I know it could be helpful to the care, but if every step of the way there's a second opinion, you may not need a second opinion every step of the way, and we should be mindful and budget out when the best time for the AI recommendation should be used. Otherwise, you could be creating an overly cumbersome system, and physicians already think these systems are overly cumbersome. Let's not make it worse for them. Let's use this appropriately, make it a good tool, but let's not overdo it. Where that fine line is, we don't know, and we got to start thinking about these things as they're integrated into these systems. Another key component in preparing the information for today's presentation is, one of my biggest criticisms about the electronic medical record when we were rolling these off the shelves 15 years ago was that these vendors never really thought about how the electronic medical record would look like on paper if there's been a request for the records after the fact. We all know by now it looks nothing like what's on the screen, and you can't really produce what's on the screen, and the whole host of issues associated with that, how difficult it is in defending or preparing witnesses for deposition when, the printout of the electronic medical record is 100 pages, and you have to go through 100 pages to answer something that was on paper, on one page. And if it was a patient's vital signs, for example, at a given date and time, all those types of things, you have to go through 100 pages. So not a lot of thought process was made on how electronic medical records, when printed out on paper, would look. And now, some systems are producing read-only electronic medical record systems. We know that now patients can access their, through the Cures Act, they can access their electronic chart and see it electronically. But when we get to the point where AI is actively making recommendations for treatment or tests, how's that going to appear on the record? If a patient's looking at this case, whether they're a plaintiff in a lawsuit, they've asked for the records after their mom and dad died, whether they're looking at the records online as an act of treatment that they're undergoing things, how's that going to look? What are they going to see? how will a non-trained medical professional interpret the recommendations being made by AI? Is there going to be a statement? Are you going to have to separate that out and print it all out? And how's that going to look? Because it's going to be important. So keep that in mind as we move forward, because it wasn't thought of the last time. So let's learn from our mistakes. How is that going to look? How will that, again, that non-trained professional who doesn't know how to use that system is going to look at their medical record and see, again, using the worst case scenario where the computer thinks that a finding is suspicious and the doctor does not. How's that going to look to a person, an untrained eye who's going to be looking at that? So keep that in mind. Another potential pitfall with an over-reliance on AI is that you could have a large class of patients who are impacted by bad AI recommendations if the bad AI recommendations are utilized by the physician, and you can unleash a whole class of plaintiffs based on the AI. So it's just a fact of a fact of using AI. If you're going to be using it more, and there's one error in the algorithm that results in multiple injuries to a certain class of patients, it can be essentially a class action lawsuit based on that AI recommendation. You're going to have increased exposure. Another interesting issue that we should anticipate is that if there is an inquiry why an algorithm made a certain recommendation, how are you going to explain that? How will it be explained? Some people refer to the algorithm as the black box because the black box is the algorithm, and just like you can't ask Netflix, why do you recommend I watch Arrested Development series? How did you come to the conclusion I would like that show after watching, I don't know, House of Cards or something like that? How did you come to that conclusion? Well, Netflix doesn't give you that recommendation. Amazon doesn't give you that recommendation or doesn't give that explanation if you ask them, why are you recommending I buy drywall screws when I'm buying a drill? They don't explain that. But in litigation, you can anticipate, or if there's been a bad event that's been a decision based on AI, there's going to be an inquiry, and there's going to be an inquiry by health risk management why it came to the conclusion that the incorrect decision as well. How can you explain that? If there is a request for the algorithm and how it's put together, can it be produced? If the algorithm has been changed in any way, other variables added, can you produce the algorithm as it was before the change or after the change, or explain why certain things were added? Will the algorithm that was used 2 years before the lawsuit's being filed, will that be preserved if it's been changed? How can you? These are things, again, we need to think about. We should anticipate that there's going to be errors based on AI, and when people want to get to the bottom of it and start looking into why the AI wanted to or made recommendations in a certain way it did, people may want to scrutinize that for good and bad purposes. We need to think about how we can go about and do that retrospectively, whether it be a month, 2 months, 2 years, 3 years, 4 years down the road. What this means is that it's going to be even increased collaboration between our vendors and the IT departments, and along with everything, as these EMR systems become more complex because we're introducing the AI into these systems, it could increase exposure in medical malpractice cases to the hospitals and healthcare systems that use them. And how and what the theories are, that's for another day. We could spend 2 hours on that. So we're coming up with about 5 minutes left in the program. I just want to leave these tips to you. These are like the most important things I think you need to start thinking about at this point. And we know there's going to be a lot of issues moving forward, but these are the main points I want you to take away, is that as we go down this journey and this path with AI, again, we're at the beginning of this journey now. Understand that in the very near future, to the extent we're already not collaborating with risk management, IT, and the medical records department and our vendors, we're going to have to work with them even more so as these electronic medical record systems become more complex. We're going to need to maintain the history of changes to the EMR platform as well as the black box. There's going to be that retrospective evaluation, whether it's years or months down the road. We need to be able to know how to preserve those things. We should start thinking about how they can be preserved, or if they can be preserved. And if they can't be preserved, explain why, so that when it comes up after the fact that you can't preserve it, that you have something that looks legitimate that explains why these changes cannot be preserved or identified. I'm fairly certain they can, but we just need to start thinking of that now. On the issue of transcription, where we're seeing AI used right now, continue to stress the importance of physicians proofreading their work to not become overly reliant on AI. As we increase the use of medical devices, be careful of the calibration and setting issues. You want them to be accurate and good, and if they're not calibrated correctly, you can make making incorrect decisions. So again, moving on to the next bullet point, AI in treatment recommendations and diagnosis, it augments. It does not replace medical decision-making or communication with patients, using the example of the automated results, automated calendaring. These systems should not replace that interaction. It's harder as we embrace these technologies to remember that. It's human nature. We need to remind our staff of the human element to the practice of medicine, and it should never be replaced by the computer. Documentation standards. Think about that now. When the AI and a physician are not in alignment, do we need a new piece of documentation, a new form of documentation that succinctly and accurately describes the reason for the disconnect, and whether we want that, whether that's a good idea or not. You can argue it both ways. I'm looking at it primarily from my example, my position as a medical malpractice defense lawyer, where it may be an issue in litigation. It may not be feasible. It can be cumbersome and problematic, but we need to start thinking of these things now. And lastly, as I just talked about a few seconds ago, we need to think about when a patient's reviewing their record, how the AI recommendations will appear to them if they see it. And particularly, again, if there's a situation where the AI and the physician, their entries are not in alignment, how should this appear on the screen? How will you differentiate what the clinician findings were from the AI? And with that, I think I'm on the hour. I'm going to advance the slide to what questions you may have, and let Michelle and everybody else talk about the other things in terms of getting credit and how to submit questions. And I thank you all for participating. If you're hanging up soon, and my information is in the materials, please feel free to contact me at any time about the questions you may have. And with that, Michelle, would you like to take over?
Yes, thank you so much, Matt. That was great. So this is the end of our slide presentation, and we have a few minutes for Q&A. If you have questions, you can use either the chat box and direct the question to all panelists, or the Q&A box. It's either on the right-hand side of your screen or the bottom right. If you click on the chat, or the three dots will pull up the option to open those boxes for you to type. I do have a couple questions here. Would you recommend that facilities put a disclaimer in the medical record if they're using treatment recommendations made by AI?
Yeah, that's a great question. I think that kind of goes through with what I was talking about. Like, if the AI recommendations are on the record, which they will be, how is it going to look? And perhaps you may want to put language in your record that says, this recommendation is by, an algorithm, by the computer. It does not become the end decision maker. This information is to be used by the clinician to assist in making a treatment recommendation or diagnosis, something along those lines, because then it explains to the patient how this information is going to be used. Because you run the risk that, if in using an example where there's non-alignment between the physician and the AI recommendation, you want to have the patient understand that the AI is not the decision maker. It's still the physician. It's still a physician. It's a physician making the decisions, not the AI. So you may want to put a disclaimer in there just to it assists the physician as well as the health system by putting that disclaimer in there. So that's something to consider.
Okay. Will we ever get to a point where the EMR can be printed in a paper chart format?
Oh, well, I don't think we'll. That's another good question. I don't think we'll ever get to where you can put the entire EMR in a paper chart. I mean, I see that. I'm aware that there are some systems are producing which is called like a one-dimensional electronic version of the EMR. What's amazing is 15 years later, we're still doing things the same way we did back in 2005 when we printed out the record, and there's been no real, as far as I know, no real improvements in that regard. But I'm not certain that we can ever reproduce, with the electronic medical record in general, that you can reproduce a record as it looked on a date when treatment was rendered perfectly. There's just so many variables. EMR systems change. There's new vendors. The templates change. The drop-down options change. There can be additions, subtractions. I don't think you can ever reproduce a record as it looked like on a certain day, unlike the paper record, and that's where it was better. But I don't think we'll ever be able to reproduce what's in the electronic medical record in the paper form. That's just my humble opinion.
No, that's exactly why we have you here, to ask you all of these wonderful questions. How about when doctors are using AI to dictate? Mm-hmm. And they're, we spent some time today talking about how there can be errors with that dictation piece. What about when a physician adds a line in their note as part of their dictation with a disclaimer that they're using AI to dictate? Does that disclaimer really have any impact?
Yeah, I see the chat here. That's an excellent question. I think yes and no. It can explain why there was a medical documentation error, but it doesn't defend a medical documentation error. Proofread. It's real simple, Doc. Proofread. Make sure it's accurate. It's your responsibility. It's your patient. Proofread it. It can explain why there's perhaps misspellings, but if people are using the dictation to treat a patient, and even if it's an abbreviation that's used incorrectly or put in wrong, that could have a bad effect down the line, and that's not something we want. So it can explain, but it doesn't defend, I guess, is the best way to answer it.
Yeah, that's a really great explanation. Thank you. What about jurisdiction? Can smartphones or remote devices impact jurisdiction of where a lawsuit is filed?
That's another good question. It could, but it depends on the laws of your state where you're at. I'm presuming most people on the phone are from Pennsylvania. There may not be, and each state has a different rule in this respect. But the question, the hypothetical comes up. What if you're a doctor? And I guess this can come up in telehealth too. But what if you have a telehealth decision, and you can, it's synonymous with smart devices as well. But if, let's just say that the doctor's in Colorado making decisions on information he's receiving from a patient in Kansas, and while the patient's still in Kansas, he has a bad outcome and dies. Can the doctor in Colorado be sued in Kansas? It depends on what Kansas's law is on that case, but because the patient's in Kansas, where there's an error that comes up, whether it's a medical device or a remote device that's an error, or the advice being given by the physician in Colorado, there's an argument it can be that the Colorado physician could be sued in Kansas, and depending on what the jurisdiction is, maybe one venue is better than the other. The rule in Pennsylvania is that physicians can be sued where the medical treatment was rendered, and using a telehealth or a medical device situation, if they're in Pennsylvania, watching a patient in Ohio, the rule in Pennsylvania is you're sued in Pennsylvania because the physician's sitting in Pennsylvania making a decision there. But that's Pennsylvania's law, and that may not be the law of other places. So, yes, you are potentially placing yourself at the mercy of another jurisdiction the more we rely on these remote devices and telehealth.
Mm-hmm. I think that's going to be really interesting, as we use these technologies more, and especially in rural areas, with getting specialists to patients and access to care. It's going to be very interesting to see how that plays out. So that is all of our questions for today. Again, Matt, thank you so much. Thank you again for joining us today. If you have any issues or questions, please feel free to reach out to Shelley Meixel at shmixell@pa.gov. And that concludes our webinar.